May I invite Poonam to formally introduce Samir, or well, introduce is, not the right word. Welcome Samir today to this event, and we would like to hear from him what he has to say about the past, present, and future of pediatric oncology in India. Over.
Thank you, Amita. And a very happy Doctor's Day to you, Amita, as well as to all the doctors who are here with us today. I do want to say a couple of things, and one of them is that this is the first time that Dr. Amita and her team organized Doctor's Day for us. And I can see the difference because with Amita, it was okay, what do the doctors really want? And I want to tell you that our journey since we started has been a lot of learning from all of you in terms of what our families want, what our patients want. A little bit of teaching from us also as patient advocates to say, no, Dr. Samir, you really have to see the patients. You really don't have to insist on blood. You really don't have to insist on certain things. You have to see our patients even if they come out of turn. So a little bit of, give and take. But most importantly, I just want to say that yes, we have learned a lot. And every year we have celebrated Doctor's Day to honor, to thank, and to respect all of you. But this year was special because Amita said, forget all those other gifts you give. Let's get the survivors' paintings. Nothing matters to a doctor more than seeing his survivor outside his door and to say, okay, this is something that I've achieved. And you know what? I heard Samir say this also, at least more than once. I think a couple of years ago at Hamdard, maybe a year ago, we did a survivor program from IRCH. And my God, the way his patients were so happy, his survivors, I think, your survivors really, really, really thank each and every one of you for what you do for them, to help them to survive, to help them to thrive. So a big thank you to all of you for that. And Samir, welcome to today's event. It's different for us because we decided to organize a talk. And who better than you, Samir, as the head professor oncology at AIIMS, as a doctor who has taught not only Sonal, me, but so many of us how we can do our work better, as one of the most eminent pediatric oncology researchers for us, as somebody who sees over 10,000 patients a year, there is so much that you can tell us, not just about the past, but about where we are with pediatric oncology today. And what about the next 5 years till we get to our 2030 goals? And what about the next 10 years? Will we see soon rather than later what Sonal has always dreamed of, that every child survives? And what is it going to take for that to happen? We all need to work closely with you all the time. We work collaboratively with you and all our treating partners and centers. But today I invite you to share with us your thoughts on what was the past, what is the present, and what does the future hold for us so that our children survive and thrive. Over to you, Samir.
Thank you, Poonam. Thank you, CanKids. Thank you all for this honor. I'll share my screen and from there I'll take it forward. It is on the desktop. Desktop. ये
स्क्रीन देख नहीं रहा है सब कुछ साफ दिख रहा है लेकिन काम नहीं हो रहा
Yes.
हाँ जब चाहते हैं तो डायलेट करते हैं.
Okay. So is my screen visible to all?
Yes, Samir, we can see
And
you.
I will just change my slide so that I know that it is also moving. Has it moved forward?
Yes, sir.
It has moved forward. Okay, thank you. Thank you. So today in the next 20 minutes, I'll be talking to you about the past, present, and future, how I see the future of pediatric oncology in India, what I think should be to reach our goals at ease. And the scheme of my talk would be the following: evaluating the past, and I'll use the classic example of acute lymphoblastic leukemia, how it has emerged, what is the current status? And when I say the current status, it is the last decade, how we have progressed. And on the future, about my thoughts as to what will impact most. So we are almost 1.5 billion, with 25% of the population under 15 years and almost half the population below 30 years. And India has about 1/3 of the world's new cases of childhood cancer. The past. So I'm not going to dwell too much on the past, but at least few slides to just tell you that in the past we had very few pediatric oncology specialists. The care was concentrated only in the metros. We lacked standardized treatment protocols. More importantly, we had absence of reliable outcome data, and we had high mortality due to late diagnosis and limited access to specialized care. So let me just go back almost 40 years, 4 decades back. Probably whatever little was known about patients who were treated, this is not outcome of ALL, but those who underwent treatment, the outcome of ALL was perhaps less than 15%. And that's when Dr. Shanta from the DRC in the US. So there she said, our children are dying. I will find a solution and come back. Not many people come back, they just say it. But 6 months later, he developed a protocol, and this protocol got started at Chennai, AIIMS New Delhi, and the TMH Mumbai. That was the MCP 841, the multi-centric protocol, started in the year 1984, and it was the first such protocol. The aim was to introduce uniform diagnostic criteria and to have a standardized treatment protocol for ALL. It was generally, this protocol was more intensive than that was used at that time in India, and it did carry the risk of more toxicity. But everybody felt that the risk was worth taking because anyway the outcome was below 15%. So from this data, out of almost 1,000 patients that were treated across 3 centers, there was a finding that the remission rate was 85%, toxic deaths were around 15 to 20%, relapse rates were still around 30 to 40%. And when data from all centers was pooled, we could get nothing which could emerge significant to say as to what would impact survival. Here you can see Dr. Advani, Dr. Sagar, Dr. Arya, Dr. Manorma Bhargav back there, and they all pondered as to we have done a big study and we have not got an answer as to what can predict. And they thought over it again. This is again Ian McGrath and his partner Melissa Addy, who are no more now. And on the right side, if you can see, it's me and Dr. Gauri Kapoor. That's back when I just came back from the US in the year 2000. Which was the AIIMS CTR 0204, the second protocol, and that got started in the year 2004. The strategy was somewhat like MCP 841, but there was increased exposure to some drugs which were thought to improve outcome. And one of the changes that happened was that the cranial RT was brought to a much lower dose than what was used in MCP 841. Again, the CR rates were somewhat similar at all the 3 centers. The toxic death rates varied. At some centers it went down, and at some centers it increased. And the relapse rates went down. But again, it got compensated by little more toxicity and a lower relapse rate. But ultimately, the outcome was similar to MCP 841. So this was the data up to 2010. We had 1,000 odd patients from MCP 841. PGI Chandigarh had a data of around 600 patients. CMC Vellore had a data of around 300 patients. But that data of 300 patients was collected over 3 decades. We must have had at least 300,000 ALL patients. The outcome was available for only 2% of the total cohort. And of this data, 1/3 of the data was only in the form of abstracts, which is typically not well peer reviewed. So to really cut it as a basic summary statement, the outcome of majority of Indian children with ALL was actually unknown till 2010. The data on other tumors was even less than this. So what has now happened in the transitioning years and the present? We have progressed in the last decade. We have tried to unify several centers. We have tried to record data, including abandonment, but we are still far from that. We have formed a group, which I think is the biggest success of the last decade. That is the INPOC group. The growth and development of pediatric oncology super specialty training programs has also increased manifold. Several hospitals across country, in all the metro hospitals, have pediatric oncology units, at least in the private sector. And some of the government sectors also have pediatric oncology units. INPOC started in 2008 with Dr. Kurkure and Dr. Anupam Sachdeva taking the lead. And then in 2008, there was another thought process as to how INPOC has to grow. And the team then decided that they will focus on multiple and almost all pediatric oncology tumors. It started in 2015. The INPOG grew from 25 different subcommittees. Within the first 6 months itself, 3 subcommittees gained momentum. By the end of 2018, you can see everything was flooded with activity. Every single subcommittee of ALL, AML, lymphomas, CML, neuroblastoma, retinoblastoma, everything was active. Trials had started, the recruitment was on. And the recruitment reached almost 12,000 patients by 2020. And today, I'm glad to say that this number has crossed 30,000, 25 to 30,000. The classic, one of the key outcomes of the INPOG has been the ICICLE study. And this is a big data where multiple centers collaborated and we were able to come together, standardize MRD and come for an outcome on ALL. I'm not talking about what the outcome is, but what is important is that people came together, thought together, and came with an outcome. What do I see as the way forward and the future? So I've talked about the past, present, and the next 7 to 8 minutes, I want to talk about the future. So there are some non-modifiable factors that we have to deal with. That is our population. And I always say that when we have a big population, it is our minus point as well as our plus point. So what has to be done to tackle this issue? And I don't call it a problem. I'll just say that it is how we are. We have a big population and we have a lot to learn. As one of my teachers said one day in the US, when somebody had a lot of admissions, lot of patients on one day, and he said, I'm busy, I had a lot of patients to deal with, I got tired, I had too many hits. And my teacher told that resident, you could have used a better term, that you had so many learning opportunities to learn. So our patient population, which is a big population, has a lot to teach us. All our patients teach us. That's what I keep telling everybody. Today also I learn every day in my outpatient. Anyway, to cover this population, we need to increase the coverage. We want every single patient to come under the umbrella, which today is only up to 50% as I come to know. So we have NGOs like CanKids KidsCan, which are expanding the coverage day in and day out with their hard work. The new ISCAL trial is now no more focused on the main centers or the search and the so-called tertiary care centers. It's a hub and spoke model. So it's gone beyond the tertiary care centers and trying to get the icicle at all other centers. The super specialty training, I feel, is already on track. I would say that training the non-specialists to do specialist work in areas which are not reached by trained manpower is also one of the things that we all have to do to increase the coverage. So what's the transformation of care? What are the things which I believe will improve the quality of pediatric oncology care across the country? The number one point is address the disparities. Address treatment abandonment. These two first points are the most paying points. If you were to invest money in the first two, the reward is going to be the maximum. Provide holistic survivorship care because that is building up all the way. And I'm very much interested in point number 4, developing locally based care delivery or shared care models. And develop pediatric palliative care as well. Because the significant, if we say that a lot of our patients are presenting in an advanced stage, metastatic stage, we need to have good palliative care for these patients. I said enhancing survivorship care. We have now a lot of survivors. We need to recognize their problems because that is a big population. We have treated several. Now that forms a big population and we want each one of them to be productive. Reintegration is very crucial for us to be successful, for those patients to be successful. They survive, they get cured, but then they have to be socially reintegrated. So I'll just put a question. Which of the following will bring maximum impact in future? NGS, multiomics, immunotherapy, CAR T cell therapy, gene therapy. All 5 fancy terms. I do all except the last one, but I also know that this will not bring the maximum impact for the population. At the same time, I'm not saying that you have to ignore this because we have 2 Indias within India. We have an India which can access everything that I have stated. And not only that, this India also has to become the hub for other low middle income countries. So I'm not ignoring these five impactful interventions. It's just that they may not have the maximum impact on the other India, which we have to bring to that level. I gave a talk 2 weeks back at some place, and I talked about the innovations that India has done. And somebody in the audience asked me, Dr. Saab, what you have stated on the research done in India, we can only use if it comes in the guidelines. And I wondered what guideline is that gentleman talking about? What guideline? Are we talking about NCCN guidelines? Are we talking about Children's Oncology Group guidelines? Are we talking about ESMO guidelines or what? Why do we always have to believe in guidelines outside India? So I will say that we need to address our unique problems in our locally adaptable ways. And I say with an underlined, bold underlined statement, believe in local guidelines, believe in ICMR guidelines. In your write-ups, when you write an article, quote the articles from India, quote Indian references, innovate with locally viable options which can actually go to the masses. If we have 1/3 of the world's childhood cancer cases, how do we expect that that countries which see less than 5% of the world's cancer cases to look at our problems? Let me address one common problem, a financial unaffordability of many modern molecules. TMH came with this randomized study on low-dose immunotherapy, and the cost was still amounting to 300,000 rupees. This was an adult study. The average income of an Indian household average is 150,000 as per the 2020 data. So 330,000 Indian rupees per month is still a big number to tackle. Another concept, metronomic therapy. You all know this is a metronome. And it's basically routine chemotherapy drugs given at lower doses at fixed intervals. And not only chemotherapy drugs, even other agents are given which are non-chemotherapy drugs like metformin, statins, valproic acid. And a term that people like to use is metronomics. We had used a regimen combining 4 agents, thalidomide, celecoxib, cyclophosphamide, etoposide, and we were able to show that this regimen actually works in non-bone sarcomas. This was published in 2017 in JAMA Oncology, and we were also able to show that this very regimen is actually equally effective as pazopanib in other soft tissue sarcomas. I'll switch gears and tell you about what COVID pandemic taught us. It was a very tough time, but we learned for the first time online meetings. Treatment innovation, that's the first time we learned that you can cut down therapy into fewer days. We learned about shared care models during that time. We learned about teleconsultations during that time. Had COVID not come, I'm pretty sure that this 4 or many of these things may not have emerged at the speed at which they have emerged now. Telemedicine and shared care is certainly possible for those who have completed their treatment and who are on oral therapy. We have evaluated this in multiple studies from our center, both in childhood cancer and adult cancers. I'll now ask you, based on whatever I've said, what do you think are the keys to successful future for pediatric oncology in India? What are the things that we need from our team members? We need to be very intelligent. We need to work very hard. We need to have novel ideas to tackle our local problems. We need to have a lot of money. Maybe not listed here. But I still feel that the biggest quality to change, I feel, is not one of these 4. Everything, if we work hard, if we work hard, if we are intelligent, but if we don't work together, it would only be Brownian motion. If we have novel ideas, multiple people have novel ideas, but we don't come together, it will still be Brownian motion. We get a lot of money, but if we don't know how to use it effectively, it would still be money wasted. We need to have a common goal. We have to shed our egos and we have to work as a joint family. And I'll add one more term. I like this term. A joint family, not just having multiple people under one roof. Joint family where the kitchen is common. Everybody works together. You have a central pool. You work together. You are growing that family and growing our pediatric oncology patients to be cared for in the best possible way together. No need to replicate or duplicate. Work together. My summary for future, my takes: increase coverage and focus on the disparities. Number 1. innovate locally rather than ape others. Believe in your guidelines. Work together as a joint family. These are my 4 takeaways for the future of growth of pediatric oncology in India. Not just pediatric oncology, I would say the growth of entire oncology in this country. These 4 takeaways are there for me. Thank you very much. I want to thank my team members. I want to thank the All India Institute of Medical Sciences, which has guided me for the last more than 2.5 decades. My temple, that's what AIIMS is for me. And our country, which gives us this population, which gives us all these opportunities to learn so much. Thank you, India. Jai Hind.
And I now welcome Dr. Manas Kalra, who I think, along with Dr. Banavali, is kind of the head of this very large joint family that we have in his capacity as leading the PHO IAP chapter. Dr. Manas, may I request you to welcome our, Dr. Pramesh to our audience. All of us, well, I can't again introduce is the wrong word, but welcome him to this meeting formally.
So, a very good afternoon, and please bear with me. There might be a little bit of disturbance. I'm just in the middle car, and my close friend and family is waiting somewhere. So, but I had to listen to Dr. Bakhshi, and I'm also going to stay tuned to listen to Dr. Pramesh. And we are really obliged that we have these 2 star speakers, and they are addressing us on this day of Doctor's Day. So, a lot, first of all, a lot of big congratulations to CanKids to get all of us together and acknowledge the role of doctors on the Doctor's Day. So, thanks to Poonam and her team for doing this. And, I bring a lot of love and wishes from Gangaram Hospital, a pediatric oncology unit. And we were recently very privileged because the President of India came to our hospital, inaugurated our new building in the cancer center. And the best thing was that, in the 27-minute that she was in the hospital doing, many things, she spent the maximum time with children with cancer. That is what she wanted to do, to just listen to their stories and ask them as to what their diagnosis is, what their problems are, what their challenges are. And it was really heartening that the supreme leader of the country was worried about children with cancer, and she spent time with that. So I think we are in a position to push the cause for childhood cancer further, and initiatives that CanKids and NCG and everyone else takes, are really, really important to push this cause further. So it gives me immense pleasure to welcome Dr. C.S. Pramesh, whom we all know is the director of Tata Memorial Institution, and he is also heads the National Cancer Grid. And, really speaking, Dr. Pramesh and his vision is changing the way cancer, not only childhood cancer, but cancer would be managed in India. If I start talking about him and his achievements, is going to take another half an hour. He's a very, very accomplished person, a very, very respected person in the oncology community. And, he set us such an example for all of us by making and leading this national cancer grid that, we understand that how a multi-stakeholder, association can take the cause for cancer forward in our country, where there is, huge scope of improvement of outcomes of cancer. So thank you, Dr. Pramesh, for agreeing to speak to us. And we all are waiting to hear the words of wisdom from you. Thank you.
Dr. Pramesh, before you start, if Vikas is there, can you formally present you our tribute?
Yeah, I was just coming to that.
Yeah.
Thank you very much, Dr. Kalra, for that kind introduction. But before I start, I have a surprise visitor here. Maybe you can
So Vikas is a retinoblastoma survivor who was treated at the Tata Memorial Hospital many years ago. His personal journey, very eventful. He visited 22 hospitals before he reached Tata. He's now a proud survivor and is helping other children. He's an operation manager for the West Zone of CanKids division. And we are so proud of you, Vikas. And Dr. Pramesh, we hope you'll find place on your wall for this lovely painting from one of our survivors and this handmade card. Thank you. Thank you so much. Thank you so much.
Thank you very much. That was very touching and very unexpected on this wonderful day. Can I share my screen?
Yes, sir.
Great. First of all, a happy Doctor's Day to everyone on this call. And thank you, CanKids, for this opportunity to be part of this wonderful ceremony. I feel like a bit of an imposter here because I'm not a pediatric oncologist, but nevertheless, I think most of us have our hearts in children's health, and this is what I will bring from the National Cancer Grid approach as well. So what I'm going to do over the next 15 minutes is to briefly describe how we approach the overall issue of childhood cancer care within the Cancer Grid. For those of you who are not familiar with the Cancer Grid, this is how it started. This is the genesis or the birth of what the National Cancer Grid was about. When we looked at 75,000 patients who visited us at the Tata Memorial Hospital, and all those small dots that you see here are patients who were geotagged based on their location of residence. And while the 34% of patients who come from the state of Maharashtra is fairly understandable, what was very disheartening to us was the fact that we had a large number of patients coming from thousands of kilometers away just to access basic cancer care. And we thought we needed to address this through a more disruptive approach than just coming up with newer cancer hospitals. Added to this is the projected burden in India, which is likely to go up almost by 60%, both by way of new diagnosis as well as deaths due to cancer in just 2 decades. And we clearly didn't have the ability to manage this without a more united approach, just like Samir mentioned in his talk. So over the last 12 years since the National Cancer Grid has been in existence, we have covered most of the centers in almost every state and union territory in the country. We now have more than 370 member organizations. We've expanded the scope beyond just cancer centers to include research institutions, patient groups, professional societies, and charitable organizations across the country. And between these centers, we treat more than 850,000 new patients. This is both adults and children every year, which is approximately 60% of all of India's cancer burden. So what this gives us is the opportunity to scale up initiatives fairly rapidly within our member organizations. The 3 main pillars on which the Cancer Grid was created originally was first to have uniform standards of cancer care, thereby negating the need for patients to travel thousands of kilometers to access care, to develop trained human resource, and to be a ready platform for collaborative multicentric cancer research, much of which you heard Samir mention in his talk about what was required in pediatric cancer care. And I'm pretty sure that he does accept that these are problems in adult cancer care as well. And finally, what has been a more recent responsibility is the 4th pillar, which is to frame national cancer policy. When it comes to pediatric cancers in India, I'm preaching to the converted here. We have more than 60,000 new children diagnosed with cancer every year in India. And while in the ideal circumstance, you could have a 70% cure rate with timely, appropriate treatment, there are several hurdles that come in the way of a child who's been diagnosed with cancer. The first of something of delayed diagnosis, which is quite evident, not just in childhood cancer, but in adult cancers as well. Dropouts of treatment. Samir did mention this about abandonment of care as well. Personally, I don't think it is abandonment. I don't think any patient or any child or any parent would want to abandon their treatment. It's a failure of the system that has forced them to drop out of their treatment. And hence, I look at this as a systemic failure, which we need to address from a health systems approach rather than from a patient's perspective. Financial toxicity, again, something which Samir mentioned, the average costs of treatment have gone up substantially in the last few years. And this has made cancer care out of reach for most of the patients within India, and the limited infrastructure that we have in several parts, especially in smaller towns and in rural India. So the NCG approach has been multi-pronged. Our emphasis remains high quality, standardized care across all centers, care that is affordable, building of capacity, making sure that all our decisions are data-driven and not opinion-based, and finally, a strong emphasis on multi-sectoral collaborations, which is reflected in our membership, which is far from being only medical-centric. And most importantly, what we have at the heart of what the National Cancer Grid works upon is something more philosophical, which is the equity imperative. We clearly realize that in childhood cancer as well as in adult cancer, there is an urban versus rural gap, which translates into differences in survival. There's a gender gap. However much we might want to ignore it, we do know that the girl child is not given as much treatment or expenditure on treatment as the boy child. We need to move from working on pilot mode to scale, make sure that this is available at every single center or every single healthcare provider in India. The access to high quality, affordable treatment at patients' doorsteps. We still haven't addressed the issue of survivorship long enough. And most importantly, what we feel is an approach of no child left behind that we keep at the heart of everything that we do in pediatric oncology within the National Cancer Grid. We wrote about this a few years back when we looked at how we approach technology in cancer care. And I think Samir mentioned this as well in his talk. When we typically talk about what constitutes medical progress, we usually equate it with cutting-edge advances, whether it's ASCO or ISMO or any of the leading cancer conferences. The majority of the research or the celebrated research is focused on areas like targeted therapy, precision therapy, immunotherapy, CAR-T, robotic surgery, proton therapy. And healthcare systems, to a large extent, invest very heavily in these advances. And I say, as Samir mentioned, we need to invest in this, but not at the expense of something that is far more basic. Let me give you a statistic about the access for pathologists globally. In high-income countries, there is one pathologist for every 15 to 20,000 people. In Africa, it is one pathologist for 2.3 million people. So if we cannot assure even the most basic of diagnostic tests, which is pathology, what are we doing talking about targeted therapy and robotic surgery and proton therapy? We looked at, again, some of the differences in outcomes in several common cancers, some of which are pediatric as well, between various countries. And these are including some of the high-income countries as well. And you can see that with most cancers, you see anywhere from a 15 to sometimes a 35% difference in 5-year survival, depending on which part of the world you were from. So it did not matter what stage of disease it was. It did not matter where you were born, what you were born. It just mattered on your PIN code. So it actually, more than the genetic code, what really seemed to make an impact was the PIN code on which you were born. And this is one of the areas that we are trying to address to narrow this gap between high-performing cancer centers and not so high-performing cancer centers. And in the same paper, we advocated for 3 major shifts in philosophy. The first was to change the global mindset and look for interventions that are truly value-based and not just based on what was glamorous in cancer research. The second was to fund human capital and social development, invest in people, invest in basic technology, and invest in safe, affordable cancer care. And finally, to implement standards and systems of accountability. In a country which is largely unregulated in its healthcare outcomes, what we need to really emphasize is the quality and safety of care and the adherence to value-based guidelines. And we emphasized that more than moonshots, which was what most high-income countries were chasing, what we really needed was earth shots. And towards this, we've taken several initiatives within the Cancer Grid. The NCG guidelines have been in place for over 7 years now. We are in the process of revising them to the third edition. These are now resource stratified, which takes into account not just the effectiveness of a treatment, but also the cost effectiveness and the availability of infrastructure and human resource. And I'm happy to say that the National Health Authority has endorsed these guidelines, and reimbursement under the Ayushman Bharat scheme is now linked to adherence to these guidelines. Pathology quality, as I mentioned, something that's extremely critical, both in adult and in pediatric cancers. We run a quality assurance scheme, a leaner version of the College of American Pathologists quality assurance, which we offer free of cost, not just in surgical pathology, H&E, immunohistochemistry, but more recently in molecular pathology as well. And though this is a voluntary activity, more than 270 member organizations now partake of this quality assurance program. We know the importance of having multidisciplinary tumor boards. So we started virtual tumor boards far ahead of its time. It's been going on for more than 9 years now. More than 1,300 tumor boards have been conducted so far. Over 6,000 patients whose complex clinical situations have been discussed. But more than the actual patient getting benefited from these tumor boards, it has also been a great platform for case-based learning. And this has now expanded, especially in pediatrics, beyond the shores of India to involve 11 other countries who regularly do pediatric virtual tumor boards. We created a national cancer library, which offers journal subscriptions and textbooks in cancer at a fraction of the cost that an individual center would have to pay if they were to subscribe for the journal or the textbook by themselves, thereby leveraging the fact that we are a large group and using the volumes that we have to reduce costs. We have a massive open online course which goes under the portal of ncgeducation.in, democratizing access to continuing medical education, regardless of which part of the world you hail from. Going by our experience with getting substantial discounts on the journals, we got a little more ambitious in negotiating as a group for cancer drugs. So what we did was to aggregate demand from multiple centers, pool the volumes, and use a central tendering and negotiation process so that we are able to use volumes to drive down costs of cancer drugs. And what we were able to achieve in 2 rounds of such negotiations was anywhere from a 23% to a 99% savings on the maximum retail price, with an average of 85% discount. So what this immediately did was to reduce the cost of something that would cost a patient 100 rupees to just 15 rupees, thereby substantially bringing down the costs of care and making care affordable to a large majority of India's patients. And for those of you who are more interested in the process, this is published in the WHO bulletin, and it gives the entire process through which we went through. Research is the final aspect which I want to talk about, and we wanted to redefine the cancer research ecosystem. And when we did a gap analysis, what we realized was the fact that while India has 18% of the world's population, we produce only 2% of the world's medical literature. And much of this is because there is a lack of training in research methods in medical school. There is inadequate protected time for research. There is scarce funding from most organizations and a lack of identified priorities. And we addressed each of these one after the other. Many of you might have heard about the Credo workshop, which is virtually a boot camp for how to do research. We've been doing this for 10 years now. We started our first workshop in 2015. The last one was in earlier this year. And over the last 10 years, we've trained more than 500 early career researchers, clinicians, biostatisticians, and more recently, patient advocates who we feel are an integral part of steering research study design. And what the way the workshop works is that individuals, early career researchers come in with a 1-page concept note, a very vague idea at the back of their mind, which over the period of 6 very intensive days of the workshop, these are practically 16 to 18-hour working days, both for the faculty as well as for the participants. They're able to convert this 1-page research concept note into a full-fledged proposal for ethics submission. And increasingly, this has got international attention. Now we get funded by organizations like the US NCI, ASCO, City Cancer Challenge. And this is the largest group by all, and something that's very relevant to this group here. The St. Jude funded pediatric oncologists who get funded through St. Jude's to participate in this workshop. And this is the US NCI group. And in just pediatric oncology, we've trained more than 80 researchers from 24 countries from across the world. I think this has been a substantial dent in making sure that research capacity in pediatric oncology globally has been shored up. And again, for those of you who are more interested in this, there's a Lancet paper which describes this. This is a little dated, about 4 years back, so it doesn't give the latest data, but nevertheless will give you an idea of how the workshop runs. And based on feedback from workshop participants, we continue to mentor these participants in the virtual mode with newer research studies that they might have. I mentioned about lack of protected time. To address this, we created the National Cancer Grid Clinical Trials Unit and an academic contract research organization, which helps researchers with the nuts and bolts of doing research, help with study design, with statistics, regulatory submissions, contracts, insurance, everything that a doctor should not be doing while doing research, making sure that they focus on the science and not on the operational aspects. We've also funded several research projects, provided these conditions are met. It has to be a multi-centric collaboration. As Samir mentioned, there is efficiency in working together and not as single center studies. Cancers which are funded are either common or unique to the region. If it is an interventional study, it needs to be cost effective so that if the research proves the intervention to be effective, implementation is not a hurdle. Anyone who gets funded through the Cancer Grid has to commit to share their data in the public domain after the study is over. And finally, a very strong emphasis on public and patient involvement. I put up the slide just to show you a sample. This is not a complete list, just a sample of all the studies that we have funded through the Cancer Grid. And some of the studies that we are proudest of are the pediatric oncology studies, which are shown in violet here.
किरण विभाग आहे ना इथे नाही.
May I request everybody to mute themselves?
Samir mentioned about the icicle study. It was almost entirely funded by the National Cancer Grid, and the study's completed its recruitment. We are now eagerly waiting for the results of the study. And I'm fairly certain that this has helped a great deal in standardizing treatment of ALL across the country. I'm really glad that ICMR has now stepped up to fund Icicle 2. We have another study on low dose Nivo, again a strategy which Samir mentioned in his talk. We've got a study funded on antifungal prophylaxis for childhood leukemias and a response adapted management for childhood Hodgkin's lymphoma. And again, the reason I put the funding numbers here are one, the fact that we are now one of the largest funders of cancer research in India for clinical cancer research. And again, to demonstrate that we are able to do studies in India at a fraction of the cost which it would cost in most high-income countries. So again, demonstrating that contextually relevant research is by far the need of the hour. Recently, we got funded by a charitable organization to set up a Center for Digital Oncology, which again is an effort to centralize our efforts to adopt and promote digital tools, right from adopting electronic medical record solutions to looking at AI and ML research in an effort to leapfrog some of the advances that have happened in cancer control globally. This is again just a year old. Based on the success of the National Cancer Grid in India, the World Health Organization requested us to establish a similar network of cancer centers in the WHO Southeast Asia Regional Office, which we launched last year in Nepal. And more than 40 centers from the Southeast Asia region of the WHO have now set up a Southeast Asia Cancer Grid, and we're working very closely to make sure that this is a more global phenomenon than just restricted to India. We also have something that we call NCG Vishwam, which opens up the National Cancer Grid to any country across the world. And I'm happy to say that many countries from the ASEAN, from the African region, have now become members of the National Cancer Grid. So what started off as a small initiative 12 years back has now emerged as a very major initiative, which has now become an exemplar for not just cancer care globally in other parts of the world, but also for other disease areas in all LMICs. Thank you very much for your attention. And once again, thank you for inviting me to be a part of this event.